Hello everybody, today we're going to be doing a mask induction. We're going to be doing a pediatric mask induction for an ASA class 1 cleft lip repair. The age for this patient is 5 months and they weigh 5 kilograms. Initially, we're going to show you my notes. Next, we're going to do a machine check. So first, we're going to start by checking our pipeline pressure. We want at least 50 psi on the pipeline, and we want at least 1,000 psi in the cylinders. Next, we're going to check our ambu bag, making sure that we're able to hold the seal, which we are. We want to make sure that we have suction in place. We want to check our vaporizers, making sure that they're filled to an appropriate level, making sure that all the caps are tight, making sure that we cannot deliver a hypoxic mixture. I'm going to go to the back of the machine here, making sure that my scavenger system was working appropriately. I'm going to check my CO2 absorbent, making sure that it's not desiccated. And then I'm going to do a low pressure test with the manometer, making sure that I don't have a low pressure leak. And lastly, I'm going to check my high pressure system by closing my APL valve and making sure that we can hold at least 30 centimeters of water. I just want to emphasize that we have suction in place. We're going to set all of our pediatric settings on the ventilator here. We're going to make sure that we have all of the parameters set, all our EKG, SpO2, end-tidal CO2, blood pressure and temperature. We want to have all of that appropriate. All right, so now once the machine is checked, I want to have all of my emergency medications: apples, atropine, phenylephrine, propofol, lidocaine, ephedrine, and succinylcholine. And so what we want to do is we want to have rescue doses for the patient just in case of any emergency. Some of the doses include atropine 0.2 milligrams per kilogram. This patient will get a total of 0.1 IM. If needed, they will also get 0.1 milligrams per kilogram, and the total for this patient is 0.05 milligrams IM as well for bradycardia. Zofran, the dose is 0.1 milligram per kilogram. Dose for this patient is 0.5 milligrams. Decadron, 0.625 mg per kilogram, and a total of 3.125 for this particular patient. I also have my propofol for this patient, typically 2.5 milligrams per kilogram. He will get 12.5 milligrams total. And for my fentanyl, typically 1 to 2 mics per kg, he'll get 5 mics per kg. The propofol and the fentanyl will be given to blunt the airway reflex. Okay, I want to make sure I have my airway supplies in place. I want to make sure I have my IV tubing, I have my IV bag in place, my IV supplies for when the patient arrives to the OR. To measure, I will be using an RAE tube. Essentially, this tube is specific to prevent the airway from being in the surgeon's surgical plane. And so the way we measure is the age of the patient divided by 4 plus 4. And so for this particular patient, they'll get a 3.0, and then I'm going to have a bigger size as a 4 and a 2.5 as a smaller size. I want to have my different size masks, just depending on the patient. I want to get a good seal, so I just want to have various options. I will also have my albuterol dose. Typically it's 0.125 milligrams per kilogram. For this particular patient, they would get a total of 0.75 milligrams. And that's just for bronchospasm. This particular patient doesn't have any history of reactive airway disease, but in the event that they would have some kind of bronchospasm, it would be evidenced by wheezing, increased peak pressures in the ventilator. And so I just want to be preemptive and making sure I have that rescue med. So I have all my supplies ready. I have my blades here as well. I have a Miller 1. Typically for this particular patient, I would use a Miller 0 or Miller 1. I also have a Mac blade. Typically smaller patients have a bigger epiglottis, so a Miller blade is typically more appropriate. you're able to pull up on the epiglottis directly, as opposed to the Mac blade, you push up on the vallecula, which typically is underdeveloped in these kinds of patients. So we're gonna be going with the Miller blade. All right, great. So now we're gonna head to the pre-op area. I'm gonna meet the family. I'm gonna introduce myself. I'm gonna verify the name, their date of birth, any familial history, any kind of malignant hyperthermia in the history for the family, any kind of disorders. I'm gonna explain the procedure. I'm gonna obtain consent. I'm going to reassure the family, and I'm gonna evaluate the patient and see if they have had a recent respiratory infection. Typically, respiratory infections within the last 4 to 6 weeks place a patient at a higher risk of laryngospasm. And so once that's verified and they haven't had one, I'm gonna do my airway assessment, Mellon-Patty score. I'm gonna check to see how wide they can open their mouth, what kind of neck mobility the patient has. I'm gonna check if they're missing any teeth, and just overall just assessment of the patient prior to taking them back to the OR. Okay, great. So now just wheeled in my patient into the OR. I am going to go ahead and place the mask on the patient. I'm gonna hyperoxygenate. I'm gonna place a 70-30% mixture of, once I hook the patient on, I'm gonna place all my leads and everything. I'm gonna do the C3 technique, or CE technique. Essentially, this covers the nose to the bottom of the chin, and essentially allows me to get a good seal and to have good ventilation. Great, so I'm hyperoxygenating them here. I have a 70-30 ratio, and I wanna make sure that they're positioned in an appropriate manner. Typically, pediatric patients of this age have a large occipital lobe and they don't need the sniffing position, but at times you may need to place them in the sniffing position, and so you can get the angle, better visualization of the vocal folds, the align-all-my axis. And so, great. Now that I'm hyperoxygenating them, I'm gonna turn on they're compliant. This particular patient is compliant. A lot of times they're non-compliant, and so you need to immediately blast them with like 8% sevoflurane, and have them with the SLB technique, somebody holding them down, blasting the 8%, and hoping they go fast, go to sleep real quick. But in this particular case, the patient is very compliant, and so just gonna start off at 2 to 3% sevoflurane. Every 30 to 60 seconds, I'm gonna crank it up about maybe 1 to 2%, reaching my initial 8%, my goal. Great. And so now I'm looking at the stages of anesthesia. The moment the patient loses consciousness, I have now entered my stage 1 of anesthesia, and I'm about to enter stage 2. When I enter stage 2, this is the highest risk. This is pivotal because it can cause a risk of the highest risk of aspiration. The patient will have involuntary muscle movements, dilated pupils. This will essentially cause a SNS hyperactivation, which will have irregular breathing, and this is a largest risk, irregular breathing, and so it has the largest risk of laryngospasm. In this stage, you want to prevent any kind of loud environment. You want to prevent any kind of, you definitely don't want to place an IV during this moment, because during stage 2, you can cause a laryngospasm. Let's say that in the event that I had my laryngospasm, first, I'm gonna apply 100% oxygen. I'm going to do my Larson's maneuver over the massoid process, trying to break the spasm. I'm going to I'm gonna close my APL valve to about 20, and then I'm gonna provide continuous positive airway pressure, hoping to break the laryngospasm. In the event that I'm not able to break the laryngospasm, I'm gonna grab my emergency meds. I have my rocuronium and I have my atropine. Pediatric patients are very sensitive to bradycardia, which succinylcholine is known to cause in pediatrics. So the dose for my succinylcholine will be 20 milligrams IM. My atropine will be 0.1 milligrams per kilogram. Some signs of laryngospaism include the complete closure of the vocal cords. I won't be able to ventilate at all. The partial closure would be maybe like Strider for the patient, increased airway pressures, and desaturation would be one of them as well. And so now that I've pushed my medications, I have broken the laryngospasm, I have prevented the bradycardia, my heart rate's appropriate, I'm oxygenating well now, great. And I am moving to stage 3 now. Stage 3, I'm gonna go ahead and check my eyelash reflexes. My pupils are now, so that is blunted. I don't have an eyelash reflex now. My conjunctival reflex is blunted. My pupils are more constricted than they were in stage 2. I am confident that I can now place an IV in this patient. I will place an IV, once again giving 12.5 milligrams of propofol and 5 micrograms of fentanyl to continue to blunt the airway reflex. Great. Now now that I've hyperoxygenated as well, I need to turn off my nitrous oxide, hyperoxygenate the patient to prevent diffusion hypoxia for 3 to 5 minutes. Great. So now I'm confident that once I place this ET tube, that I will not, I'm looking at my monitor, but I'm also looking here at my vocal cords. Great, I see them, and I'm going to sweep the tongue from right to left, placing my ET tube. Great. I'm gonna connect them to my circuit. I'm gonna be monitoring for end-tidal CO2, fogging of the tube. I'm gonna be auscultating for breath sounds. I'm gonna be making sure that my depth is appropriate, and the way that we determine that is by the size of the ET tube. As we mentioned, we're using a 3. Multiply that times 3, and that gives you a depth of 9 centimeters. So we're at about 9 centimeters. I have end-tidal CO2. I have appropriate fogging, breath sounds, great. I'm gonna turn my SIVO, I wanna make sure that it's in my appropriate dose, so maybe 2 to 3% for my SIVO. I'm oxygenating well, so now we are going to tape my eyes. We want to prevent any corneal abrasions. We're going to tape the ET tube down, and we should be good to go. If we want a throw pack, we can go ahead and place a throw pack according to the surgeon. Make sure to document that, but in this particular case, we're not going to. Great, now we're in the maintenance phase. In the maintenance phase, we're just going to monitor them. If they need IV fluids, administer whatever is needed. There's a risk of bronchospasm, and in that event, we would see wheezing, we would see increase in peak pressures. This may lead to bradycardia if the hypoxia is bad enough. But thankfully, we have our albuterol that we can administer, and like we said, 0.75 milligrams for this particular patient. We are now ready for emergence. We are going to determine, for this particular case, the literature says that we want to have an awake extubation rather than a deep extubation. Typically, risks associated with the deep extubation include inhibited airway reflexes, and typically you may need to reintubate during this stage. Like if you extubate them deep, they may lose their airway. However, for a lot of cases like tonsillectomies, it's appropriate sometimes because there's a high risk of bleeding, and you want to prevent bucking and coughing during this type of during this extubation. But for this particular case, I'm actually going to give 0.5 mics per kg of Precedex, 2.5 mics in total for this patient to prevent delirium after and to have a smooth extubation. So great. I'm ready to extubate. I'm going to go ahead and turn off my gases. SIVO's off. I'm going to turn my gas flows up so I can wash out the anesthetic. The patient is awake. They're pulling at the tube now. Their eyes are open. I feel confident. I'm going to make sure to really suction that airway to prevent laryngospasm. And okay, great. Now I'm going to go ahead and pull the ET tube. Suction again. Patient satting fine. Feel confident. I'm going to go ahead and take him to the PACU now. Thank you.